everyone. This month, we will discuss this article, vulvar dermatosis, histopathologic review and classification of 183 cases, with the first author, Dr. Mei Chen. Dr. Chen is board certified in anatomic pathology and dermatopathology, and currently an associate professor at University of Michigan. I'm Jisun, an associate professor of dermatology and dermatopathology at Thomas Jefferson University. And here's Silvija Gottesman.
Hello, everyone. I will not be joining with video today because I'm unable to because of Windows firewall issues, but I am so happy to be here, and thank you, Dr. Chan, for joining us. We do have our monthly Dermatopathology Journal Club that happens on the fourth Thursday at 9 p.m. Eastern Time. And tomorrow we are going to be discussing one of Dr. Chan's papers. I'm going to screen share so that you could see. Let's see if that works. So this is the article from the Journal of Cutaneous Pathology, Vulvar Dermatosis, a histopathologic review and classification of 183 cases. So I am a dermatopathologist at the Ackerman Academy of Dermatopathology in New York City. And today we're going to talk about vulvar dermatoses. Vulvar dermatoses, whenever they have really well-established histopathologic features in advanced lesions, they're really easy to recognize. However, when the histopathologic findings are really early on, they may have overlapping features with several dermatoses, and moreover, their symptomatology may be similar. A lot of patients will come into the clinic complaining of pruritus. So Dr. Chan took up on this mission to review hundreds of biopsies and kind of build onto that classification that the International Society of Vulvovaginal Diseases of 2006, tried to help us with. So today we have several questions to ask her to dive into those topics. I was particularly fond that in your paper, you discussed the presence of zones of pale epithelium in lichen simplex chronicus, and that you had postulated that this change may be identical to pagetoid dyskeratosis. So I was wondering, is there a reason for using the term zones of pale epithelium rather than pagetoid dyskeratosis? In my experience, whenever I've mentioned this term, especially to residents early in their training that are not familiar with it, they usually think of something bad. So are we trying to avoid the clinician, also having the same feeling if they're not familiar with the term?
Yeah, well, first of all, thank you so much for inviting me. I'm really flattered that you guys selected this paper, even though it's a little older. So to answer your question, which is excellent, I completely agree. What we're describing as zones of pale epithelium is pagetoid dyskeratosis. And I think the reason why we didn't just call it outright pagetoid dyskeratosis is that most people, as you mentioned, are not really familiar with this term. It's not very well known or widely used. So we figured it might be easiest for everyone to understand what we're actually talking about by being a little more descriptive. And thank you for pulling up this paper that talked about this feature, pagetoid dyskeratosis. And yeah, previous papers that talked about this feature kind of suggest that these are just small clones of keratinocytes that are showing premature keratinization and hence a different in the color of the cytoplasm, but they're completely benign. And there are some hypotheses as to why these keratinocytes may show premature keratinization. One hypothesis is that these could be undergoing, or these cells could be under chronic irritation or friction, which I think fits very well with us seeing this feature associated with lichen simplex chronicus.
Yeah.
And your other point about the terminology is very well taken. I think whenever people see the term pagetoid, it might make them nervous because they associate it with extramammary Paget's disease, for example, pagetoid squamous cell carcinoma in situ, or pagetoid as in melanoma in situ. So I can see how trainees might get a little nervous when they hear this term. And it's not exactly why we avoided using this term, though, because we did discuss it in the paper. It's just more because a lot of people might not know exactly what we're talking about. So that's why we opted for the more descriptive term.
I like it. I like it a lot. I also pulled up the image from your paper. I'm going to increase this a little bit, and so that our viewers can see that it is exactly like the image that I showed before. From one of the papers that you used as a reference. And that's the paper I usually direct residents to, okay, take a read at this and know pagetoid dyskeratosis, and don't associate it with anything bad just because there's the word pagetoid in it.
Yeah. And somehow I feel like I see it more often in vulvar or genital LSC, but we certainly see it in outside of the genital areas as well. And sometimes, like when it's more like early LSC, that's something that I point out when I see, when I'm signing up with my trainees, like if they're in any way a little skeptical of my early LSC diagnosis, I'll point that out as one of the features that I use.
Wonderful.
That's very interesting. So the article discussed the presence of eosinophils in almost half of the lichen sclerosis cases, and a component of hypersensitivity was suggested, possibly the allergic contact dermatitis. Were the eosinophils present in the early lichen sclerosis or more in the late lesions? And will you elaborate on this hypothesis?
Yeah, that's a good question. Unfortunately, that's not something that we looked at more specifically as to whether we see eosinophils more so in early cases compared to late cases. If I could go back in time and have all those cases again, I probably would look into that more, because I think there are other groups that shortly after we published, or right around the time we published this article, there was at least one other paper that talked about eosinophils in lichen sclerosis. But I don't think at this point we know if they come in early or late in the process, or even before the process. We commonly associate eosinophils with some sort of hypersensitivity, including allergic contact dermatitis. And I think at least in some of the cases that we saw, it probably is a superimposed allergic contact dermatitis, because we saw eosinophils not only in the stroma or dermis, but also in a small percentage of cases, I think about 8% of cases, we see eos in the epidermis as well, which I tend to think it is a pretty good evidence that the eosinophils are kind of reacting to something that comes into contact with the epidermis. So I do believe, at least in some cases, that's what's happening. I don't think we know if it happens before the development of LS. If I have to make a guess, I would say probably after, as a secondary phenomenon, just because I think, I'm not a dermatologist, but I was told that by my colleagues that a lot of times, because of the burning and itching sensation, some patients might decide to use some sort of wipes. They might think that they're not cleaning the area well enough, and hence the pruritus, for example. But the problem with these wipes is that it could elicit some sort of allergic reaction, especially the skin in the genital area are pretty sensitive to begin with. So that would be my guess, but although right now we don't have anything to actually prove it.
Yeah, it definitely could be multifactorial. It could be from the wipes that they're using. Methylchlorosis, so thiazolinone is a common allergen that we encounter. It could be from some of the preservatives that are used in the topical medications that we apply, or sometimes even from the laundry detergent and the softeners that the patients use to clean their clothing, and that goes directly onto the skin in that area. So it is very
Mhm.
interesting. I do see eosinophils often in LS, and
Mhm.
I just always myself wondered, when do they come and why?
Did the previous study of your reference in the article show any particular allergens as a result of the patch testing they were doing?
No, that's not something that we looked into. Yeah, but I did read that a good number of people with LS have positive patch testing. So I don't recall seeing that in our chart review in our patients, but at least that's a known thing in our studies.
Dr. Chan, what are your tips for favoring lichen planus over early lichen sclerosis, particularly in biopsies that don't have that well-defined sclerotic papillary dermal changes? Doing a PAS stain and seeing a thickening of the basement membrane is certainly a useful finding in lichen sclerosis, and I teach my residents about that, and we dive into why this is happening, and it's thought to be because of basement membrane damage, fragmented expression of alpha-6 beta 3 integrin and laminin 5, and exaggerated expression of collagen 4, and that certainly does sound like a board's question answer, doesn't it? But I always do try to I'll do a PAS for LS cases, make sure that there's not also a second diagnosis of a dermatophyte, but sometimes they don't have a thickened basement membrane that could help me differentiate early LS from lichen planus. So I was just curious about your approach to those biopsies.
Yeah, I think that's the eternal question. Obviously very challenging, and oftentimes the best we could do could be just lichenoid dermatitis or lichenoid mucositis and give a differential. I think sometimes it's hard to just like even favor one over the other. And I completely agree with you. If you see thickening of the basement membrane, that could be a sign that would favor LS over LP. In my experience, I feel that LS, especially when early, I don't expect a lot of epidermal changes. So in other words, you do have a lichenoid inflammation, but I don't expect a lot of like sawtoothing of the reedy ridges. I don't expect prominent hypergranulosis. I don't expect a lot of changes to the stratum corneum in the form of hyperkeratosis. So I also feel like you typically don't see a lot of cytoid bodies. So if I see a lot of cytoid bodies, sawtoothing and stuff like that, I would favor lichen planus. I guess one caveat is that because a lot of these LS cases also have superimposed changes of LSC, which could give you some hypergranulosis, some epidermal hyperplasia. If you do run into a case like that, that would make it even more challenging, because then a case of LS could then simulate LP even more. But again, I feel like when LS actually becomes to actually develop LSC on top of LS, I think at that point, you're probably going to see more advanced changes of LS, namely more sclerosis in the upper dermis. So I think, yeah, those are the things that I go with. And also in our paper, we did describe these kind of entrapment of lymphocytes and kind of early sclerosis. So like not well-formed sclerosis. I do feel like before it becomes like a band of sclerosis, you start with some, what we call wiry fibrosis. So it's not exactly sclerosis yet, but more like wiry fibrosis in the superficial dermis. And within those areas, even though it's not a sclerotic band, you'll see some lymphocytes being entrapped in between those wiry collagen fibers, kind of giving rise to that what we call single filing pattern of the lymphocytes that we also had a picture of in the paper. So that's something that I also use even if I don't see a well-formed sclerotic band.
I'm just bringing up the
yeah
again
in figure A here.
In figure A here.
Yeah, you can see because of the early changes to the matrix, the lymphocytes can't really just randomly scatter in the dermis. They're kind of limited to go in between these thickened collagen. So kind of this single filing pattern is something that I use. And we see this in early lichen sclerosis and also like kind of at the edge of well-developed lichen sclerosis, which we kind of consider as early changes. So I think if you see good single filing, that could be another clue that I would favor LS over LP.
Yeah, that's a very helpful finding. So I'm just switching my gears to the other entities in vulvar dermatosis. So I agree that diagnosing Zun's vulvitis is very challenging, and clinical pathology correlations necessary because there's almost always some extensive plasma cell infiltration at the location. So did the Zun's vulvitis cases from your study come with a clinical suspicion for Zun's from the clinician?
So unfortunately, no. I feel that it's not something that a lot of clinicians are familiar with, especially if they come from the gynecology clinics. I almost have never seen it as a clinical differential provided by gynecologists. So unfortunately, no, but the description usually would be erosions, something more generic.
How do you approach the Zun's melanitis? Do you use that finding like a erosion and basal cell crowding as your like a first go-to histopathology clue?
Right. So your point about plasma cells was very well taken, even though it's plasma cell vulvitis. Anything that's ulcerated or eroded, you do expect to see a lot of plasma cells, especially when you're getting to the actual mucosa. So you obviously cannot just rely on that. So if I see a dense infiltrate with a lot of plasma cells, then the next thing I look for is the changes in the epithelium. So you're right. I think I do use erosion. I do want to see at least some, even superficial. I would like to see some superficial erosion in the form of having some neutrophils in the superficial epithelium, at least. And then another thing, more like from low power, is the spongiosis. I do like to see spongiosis of the epithelium, especially near the area of erosion, where people describe these lozenge-shaped keratinocytes or rhomboid-shaped keratinocytes. So we see spongiosis all the time, but I do agree that somehow in Zun's vulvitis or balanitis, these keratinocytes within the area of spongiosis kind of have this more distinct rhomboid shape to them. So I think in the figure that we briefly saw, you can kind of see the distinct area of spongiosis with those kind of rhomboid shaped keratinocytes as well. So those are like those would be the thing that I look for from low power. And then on higher power, yes, we also describe these basal keratinocytes being more crowded. And they're crowded in a funny way in that they're crowded, but they're not really atypical. They're still kind of small and uniform basal cells, just kind of line up the basal layer in a very more crowded fashion, like it looks darker from low power. But I have to say this feature is not that consistent. So I wouldn't say this is the first thing that make me think of Zun's vulvitis. And also other things that I look for at high power is hemosiderin. I do like to see hemosiderin deposition within the brisk infiltrate. I find that to be a fairly consistent feature. So even if focal, even if I have to hunt for it, I'll hunt for it.
I see. And is it same as Zun's melanitis too?
Yes, I do look for exactly the same features on penis.
Great.
So I had a question. If you can comment on differentiating these crowded basal keratinocytes and Zun's vulvitis and subtle cases of differentiated vulvar intraepithelial neoplasia in lichen sclerosis biopsies. What are the things that you look for, particularly in very inflamed specimens of DVIN, because there's LS in the same biopsy? Do you rely on P53 positivity, P16 negativity in DVIN, or do you use H&E alone?
So very good question. Another eternal question. So I think we all start sweating as soon as we hear the term DVIN. It's just such a difficult diagnosis. And so to first answer your question about the basal keratinocytic crowding in zones, I think that because those basal keratinocytes, even though they're crowded, they tend to be small and uniform. I don't usually confuse those with DVIN, even inflamed or early DVIN. For me, I like to see DVIN having basal atypia in that the basal keratinocytes get larger and they're a little more pleomorphic when you compare their nuclei from one cell to another. So there's a little more pleomorphism and atypia. So kind of, I know different people probably have different threshold for calling DVIN. My threshold is that I'd like to see at least some changes that I would consider, let's say, actinic keratosis elsewhere on the skin. It's like that degree of atypia. But I have seen other people, especially maybe more so GYN pathologists, they may have a lower threshold in calling DVIN, and it's hard to know who is right, who is wrong. Of course, it always helps to have some immunohistochemical support for the diagnosis. So we pretty frequently do P53, like you said. So I do find that to be still so far the most helpful immunostain. So in that, if it is DVIN, I would like to see overexpression or null expression. So for overexpression, I would like to see the entire basal layer staining pretty strongly, nuclear staining for P53, in addition to some suprabasilar keratinocytes showing the same degree of staining. So in other words, it has to be continuous in that area and not limited to just the basal layer, but also extending into the suprabasilar areas. So that's what I would call overexpression to support DVIN. And the other pattern would be null pattern, in which that whole area that you're concerned about distinctively have lost all P53 expression, because normal epidermis or epithelium would have kind of more scattered cells staining P53 at different intensities. That's kind of normal. But if you actually lose all P53 staining, that's also concerning for DVIN. And as far as other immunostains, I think more recently there are some papers looking at other markers such as CK17, and I know some studies also looked at GATA3. I'm more familiar with CK17 because our lab just recently brought up this antibody as a double stain with P53, basically designed just for this purpose. So what previous studies have shown is that CK17 and DVIN tend to have pretty diffuse full thickness keratinocytic staining. So full thickness or nearly full thickness, meaning all the cells, sometimes minus the basal layer, would be CK17 strongly positive. So if you see that, that could be supportive of DVIN as well, although we have also seen some cases, especially LSC, that may have that same staining pattern. So in other words, that type of CK17 staining is by no means specific for DVIN, but we do, from our limited experience, because we just brought it up recently, we do feel that it's a good stain to rule out DVIN, because if you don't have that full thickness or nearly full thickness staining, it's unlikely to be DVIN. So I would say after P53, CK17 may be the next most useful stain in this differential. And I know people do P16 a lot on vulvar skin. So I only do it when necessary in this kind of context, because usually I do P16 only if it's like full thickness atypia, your typical HPV basaloid squamous cell carcinoma look.
Fantastic. That is amazing. Thank you. Thank you so much.
You're welcome.
To share table 1 from your paper. This is what I was referring to earlier, and I'm so grateful that you had put this in this paper, the 2006 International Society for the Study of Vulvovaginal Disease classification. And I know we focused a lot on the lichenoid and then on the spongiotic. We touched a little bit by talking about allergic contact dermatitis and then the lichen sclerosis, but we shouldn't forget about the other things that can affect the vulva. And this is an excellent table table of histopathologic patterns to keep in mind. And then I particularly enjoyed figure 1 because erythrasma and herpes can always sneak up. So lots of levels, and check for those 2 things. Definitely.
I know. Doesn't it make your day when you see a case like that?
It absolutely does.
I feel like I haven't seen erythrasma in a while, though. I'm kind of bummed.
Hopefully we are not missing.
I know. I hope not.
Well, Dr. Chan, again, thank you. Thank you so much. You're such a prolific academician. Thank you for your contributions, and thank you for joining us today for this Q&A session. And I'm excited to upload this to the ASDP YouTube channel and share it with everyone.
Again, thanks a lot for inviting me. I really enjoyed this session.
It was a very helpful session. Thank you very much, Dr. Chan.
Thank you. Take care.
Take care.
Bye-bye. Bye-bye.
Bye.